my presentation today is about the types of shock, right, and how it's tested on the USMLE STEP exam. This isn't definitely for your assessments and also the paper. This is extremely, highly tested topic. So hopefully we're trying. Try to get to the concepts of how the different types of shock happen, so it'll be a good revision because it's one of the few topics which is highly dependent on your concepts because it is tested similarly in step one as well. Okay, so before we start, could you guys tell me what shock is? Can anyone tell me what shock is? Um, Okay, you know what? I'll just start with discussing, and then we can have the question answered at the end just to save time. Okay, so basically, what shock is what is it? It's a life-threatening disorder of the circulatory system that results in inadequate organ perfusion and impaired oxygen delivery to tissues, resulting in metabolic abnormalities, and if untreated, can lead to irreversible organ damage. So this is just the basic definition. The important thing here is that what you guys need to know is that there are many different types of shock, but all of them eventually lead to this. I haven't written this on the slides, but they're basically this. Maybe this was tested more in step one, not very high yield for step two. But there's three stages of shock, which are basically pre-shock, shock, and then end organ dysfunction. So what happens in pre-shock is that you start getting some tachycardia, you get hypotension, slightly you start getting oliguric because your kidneys are like the most sensitive to any changes in fluids. That's pre-shock. After, what happens after a while is, if it's not treated, you're not being resuscitated, you will have worsening hypotension. And when you have worsening hypotension, what you get is, at the same time, you can get metabolic acidosis. And when you get lactic acid built up because of hypoxia and poor perfusion, that can eventually lead to end organ dysfunction. Okay, so that's a very important concept to know, that there are basically it's a very progressive thing to have in a patient. And that's why it is very critical to treat it at the appropriate stages. Uh, the different types of shocks that are basically all the types of shock which we're supposed to know are hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. So what the USMLE exams basically test you on mainly is to an extent management, obviously, but another thing is how the parameters change in each of these shocks. So all of these shocks are basically identified by the different hemodynamic parameters, and I'll show them to you on the next slide. So these are the ones that you need to know. So basically, in each type of shock, you need to know what the CVP is, what the PCWP is, what cardiac index, SVR, and SVO2. All right. So what central venous pressure is, or central venous pressure, which is CVP, is basically the right side preload, which is basically like, the amount of blood which the right heart is receiving. Okay. The wedge pressure is the left-sided preload, and is again what the left-sided heart would be receiving. Cardiac index is just another way of saying the cardiac output per body surface area. SVR is the afterload and resistance of the circulatory system, and the venous oxygen saturation is the amount of oxygen which is found in the venous system. So there are certain types of shock that can have high venous O2, but I need you to remember one important thing. Basically, for our intents and purposes, wherever your cardiac index, right, your cardiac index right here, wherever this is low, right, you're gonna get a low venous O2 saturation. That's very important. Okay, and if you have a high cardiac index, okay, which will be seen in some certain type of shock, you get a high venous O2. Okay, so SpO2 will be high. Okay. let's just go ahead. So basically, our main discussion will be how shock impacts these parameters. Okay. Okay, so in my next slide, I'm gonna basically discuss what CVP and wedge pressure is. Because at times I've seen some students who just like try to rote learn this stuff. I'll try to discuss it and summarize the main aspects of what you're supposed to know about these two. Other than that, you guys should be good to go. Okay, so CVP and PCW. So this is pulmonary capillary wedge pressure, and this is central venous pressure. So whenever you have an elevated CVP, this is indicative of what? Uh, this means the myocardial contractile dysfunction could be present, or there is fluid retention. So any shock that can lead to the heart not contracting properly, right? Or if there's buildup or backup of fluid, excessive fluid, that can lead to an excessive amount of central venous pressure. And if you have a low CVP, that is indicative. Uh, sorry, that is indicative of volume depletion or a decreased venous tone. Okay. And the wedge pressure, all you need to know is that it's like a surrogate marker for your left atrial pressure or your left ventricular and diastolic pressure. Anything that will cause raised ventricular left-sided pressures will cause a wedge pressure to be high. Okay, these are the papers which I got these references from. Okay. Okay. So let's just start with the hypovolemic shock. So hypovolemic shock is when you have low volumes in the intravascular compartment. Okay. What are the causes? So any causes of trauma, which is external bleeding. You could have internal bleeding as well. Any cause of excessive fluid loss, such as vomiting, diarrhea, severe dehydration. All of these can cause are causes of hypovolemic shock. Okay. Um, so what happens basically in hypovolemic shock is that, so we're gonna start simple. You get fluid loss. So fluid loss could be due to trauma, for example, or vomiting. Once you've lost this fluid, you'll have low volumes of blood, right? Low volumes of fluid. When you have low volumes of blood in the body, that will lead to a low preload onto the heart, right? And when your preload is low, your blood pressure will fall. Okay. Once blood pressure falls, obviously your pressure sensors will detect this, and in response to this will increase activity of the sympathetic nervous system and the renin aldosterone. One second. Renin aldosterone system. Okay, your RAS will be activated. So why is that? Because basically your blood pressure, right, which you want to maintain, and that's the main thing that is wrong in shock. Your blood pressure leads to hypo. Your blood pressure depends on both your basically your total blood volume, right, which is in the intravascular compartment, as well as your resistance. Okay. So for example, if I'm losing my blood volume, my body is going to counteract by trying to increase the resistance. So that's why it increases the sympathetic nervous system. And this. So sympathetic nervous system, what effects does it have? It will increase the heart rate. It will cause the SVR, which is the systemic vascular resistance, to increase because of peripheral vasoconstriction, right? And at the same time, I haven't mentioned it, but right, your contractility of the heart will increase. So in this case, the heart is all right, but your body does not have enough volume. So when your resistance increases, right, your blood pressure tries to get maintained by this mechanism, but because of peripheral vasoconstriction, you will have cold and clammy hands. Now, the description is very important, because if you just remember this point, for example, and obviously the what's going on, you can get questions, right? Because there are some cases in which you will have warm hands or like dry hands, right? So that's how you distinguish shock, how the patient presents. And lastly, again, because you have low volume blood, which is facing high resistance. Why is there high resistance? Due to SVR increase, right? So when you have when you have low volume blood which is facing high resistance, it's gonna go into the the different tissue systems of the body, different organ systems, and they'll get maximally extracted by cells. So then you'll have less O2 content in the veins. Okay, so what happens is basically how your patient is presenting. You'll have cold, clammy extreme, and remember this is hypovolemic shock, right? Hypovolemic shock. So you have cold, clammy extremities, which is indicative of poor peripheral circulation. Okay, slow capillary refill, which suggests impaired blood flow and perfusion. Non-distended jugular veins. Why is that? Because again, there's reduced blood volume in the body, and your heart, even though it's trying to pump and contract at a rapid rate and with all its might, it's not able to pump enough blood because there's not enough blood in the body. Your skin turgor will decrease because there is dehydration and reduced fluid volume, and again, dry mucous membranes, which is because of dehydration and low volumes. So what will the parameters be? Okay, so I have low blood volume in my body, right? So my CVP will be low because your, this was basically your preload. I'm sorry, 1 second. Okay, yeah, this was basically your preload, right? So you have low preload. Again, if your right heart is being filled with less blood, eventually your left heart will be also filled with less blood. And you'll have low wedge pressure as well. Okay, the heart will try to counteract this by increasing the heart rate, increasing the vascular resistance, right, to increase the afterload and try to maintain the blood pressure. SVO2 will be low. Again, I told you it's because of resistance and low flowing blood. It's not flowing fast enough, so your tissues will be able to extract the maximum amount of oxygen, and there will be less oxygen left in the veins, right? But if you can't remember this, just remember that whenever your cardiac output is obviously low, your SVO2 will be low. And the main cause of SVO2 being low is obviously you don't have enough fluid in the body. Okay, just give me 2 seconds. One second. Okay, so if you guys could tell me that if you guys are clear up till now, just let me know. And if you have any questions, just write them down and we'll discuss at the end of it. Okay. Uh, I'll move on right now. Uh, just let me know if I'm audible. Okay. I'll go on to the next. Okay. So the next thing that we're doing is cardiogenic shock, right? And in cardiogenic shock, what happens is basically you have damage to the heart, right? In this case, it's not that you don't have enough fluid. There's no loss of fluid anywhere, but you're having damage to the heart, and because of ineffective pumping, you have backup of blood. So what are the causes of cardiogenic shock? You can tell by the name it's due to the heart. So anything that disrupts the heart, like myocardial infarction, which is obviously due to ischemia, myocarditis, which can be like due to any viral infection, and any cardiomyopathy. All of these can lead to cardiogenic shock, and obviously in this, the whole mechanism of shock is different. At the end of the day, all shock do leads to worsening hypotension, metabolic abnormalities, and tissue hypoxia, but the mechanisms are different. So what happens in cardiogenic shock? Okay, so what's going on? So the heart can't pump in this case, right? So your cardiac output can't increase, right? But for example, someone got an MI all of a sudden, their heart will obviously not be able to pump with the same contractile function because they have a lot of dead tissue, right? Your cardiac output can't increase, so your blood pressure falls. So as soon as your blood pressure falls, right, your sympathetic nervous system and RAS are activated again, you get an increase in the heart rate and vascular resistance. And since the heart can't pump out blood, so fluid will start backing up, right? So because I told you the amount of fluid is normal in this, right? But basically, the heart is not able to, for example, if this is the four chambers of the heart and you have ischemia over here, right? It's not being able to pump out blood. So obviously the blood will start backing up. So what happens when the fluid starts backing up, you get a rise in the wedge pressure, because I told you, obviously, if I'm not being able to pump blood, my left ventricular and diastolic pressure would increase, which would obviously cause my left atrial pressure to eventually increase. So this is why your wedge is rising. Your CVP is obviously rising too, because your left-sided preload eventually puts pressure on your right-sided heart, on the right side of the heart, and that will cause a CVP to rise and JVP rise, because this is an important sign which is seen on examination. Your SVR is increased again, because although the amount of fluid is normal total, but it's not getting to the right places because the heart's not being able to pump it out. So your vessels will constrict, leading to cold, clammy skin. Lungs will get backed up with fluid, causing you can get edema, pulmonary edema. You can find a new murmur or crackles on examination. So these are distinguishing features which you won't find in hypovolemic shock. Okay. And again, because you have low volume blood in the entire body and it's facing high resistance, it will be maximally extracted by cells. So there will be less oxygen in veins and the cells will consume all available oxygen. All right. Um, Okay. So in short, how will the patient present? So again, you will have signs of reduced blood flow to the extremity. Again, cold, clammy skin was seen in hypovolemic shock, and it's also seen in uh, this cardiogenic shock, right? Delayed capillary refill, but the one mega difference here is elevated JVP and distended neck veins because of increased pressure within the veins returning blood to the heart. You can have heart failure, obviously, where you can have heart failure signs like chest pain, palpitations, murmurs. So obviously, with the features and also the different parameters, you can distinguish between the different types of shock. Okay, so what are the parameters in cardiogenic shock? You'll have wedge pressure, which is increased because of, again, left ventricular and diastolic pressure is increased, and eventually left atrial pressure can also be increased. Left-sided, if you're getting backup in the left side, that will eventually lead to backup in the right side. So your venous pressure will increase. There's no cardiac output. There's a decreased cardiac output, which will cause the peripheral resistance to rise. Okay, to try to maintain the blood pressure. Okay, and again, I told you SVO2 would fall because the cardiac output is low. Are you guys following me up till now, or am I going a little too fast? Are you guys good? Could you just message on the group? Okay, all good. That's good. Okay, so now we got cardiogenic shock and that out of the way. Hypovolemic shock. Okay. We'll try to go on to the next one, obstructive shock. Okay, so obstructive shock, what happens in obstructive shock is basically there's no like there's nothing directly wrong with the heart in this case, but there's some sort of obstruction on the heart or the great vessels, and the great vessels obviously could be the aorta, the venous system, anything which is impairing the ability of the heart to circulate blood. Okay, and this leads to a drop in the cardiac output, and again, obviously, a compensatory increase in the vascular resistance. So obstructive shock is when there is some sort of like external source of obstruction which is not letting the heart pump out the blood. But the heart itself isn't like, damaged by an MI or something. Okay, so that is important to know. So there are a number of different causes in this. And one important thing that I want you guys to know is like for cardiogenic shock and hypovolemic shock, more or less every single case will have the same parameters. Okay. But now in obstructive shock and distributive shock, depending on the different cases, there are certain parameters which can vary. Okay, so that is very important to know. And I'll tell you in which cases it's important to distinguish and what parameters we'll look at. Okay. Okay, so these are the mechanisms of obstructive shock. For example, so pulmonary embolism, again, this isn't like, directly, pulmonary embolism does not affect the, the myocardial tissue or anything like that. It's not affecting the pumping ability of the heart in the sense of the, the contractile, but the heart will not be able to pump against this obstruction. Okay. Your tension pneumothorax and your cardiac tamponade. I will discuss tamponade in more detail because it can, the students find this a bit more confusing usually. Okay, so pulmonary embolism. So what happens because there's obviously obstruction in the pulmonary vasculature. Okay, so you will have a fall in, okay, the pulmonary embolism obstruction leads to a fall in the wedge pressure. Okay. Since there's a fall there's a fall. Okay, let me explain this like this. So basically you have, so this is the right side of the heart and this is the left side. Sorry for my drawing, but just for explanation. So basically this is the pulmonary artery, which is coming out from the right side. Say this is the right side. And eventually, obviously, the pulmonary vein goes into the left side of the heart. Okay, so the wedge pressure, right? It tells you wedge pressure, Joanna, it goes into the pulmonary capillaries and tells it's basically detected by a Swan-Ganz catheter, and the catheter basically tells you what the pressure in the left side of the heart is by going into the pulmonary capillaries. But if, for example, I have an pulmonary embolism or severe pulmonary arterial hypertension, right? So this comes before the capillaries, right? So you have an obstruction before the capillaries, right? You have a big embolus over here. So when you have a huge embolus at this side, you will not get blood to the left side of the heart, right? So your wedge pressure, if there's no left-sided preload, because of this obstruction, your PCWP will be low in this. Okay, and obviously because there's a huge obstruction there, there's your afterload increase, your right ventricular pressures increase, your right heart starts failing, your right ventricular pressure rises, and obviously, okay. So what happens here is that now that your right ventricular pressure is rising, what tends to happen is that the septum in between, right, which is normally situated like this, due to increased right ventricular pressure will cause it to bulge on this side. And basically the right ventricle increased pressure is causing it to compress the left side of the heart by shifting the septum, which can cause the left ventricle to further decrease its diastolic filling and hence lead to a fall in the cardiac output. So in this case, what the most important thing I want to tell you guys to look at the wedge pressure over here. Okay, and again, right heart failure will lead to left ventricular preload to fall and cardiac output. Okay, what happens in tension pneumothorax is that you get an increase in intrathoracic pressure. Whenever usually your pleural pressures are negative, but obviously in tension pneumothorax, due to the air filling up, right, your venous system gets severely impacted. You are not able to fill your heart with blood because of the high positive pressure on the outside and compression. So you get a fall in the wedge pressure because the heart is not being able to fill up. Okay, and again, obviously that will cause impact the left diastolic filling as well because it's being compressed from the outside by the positive pressure, and the cardiac output will fall. So this is kind of similar to your pulmonary embolism. Now, what comes different is here in tamponade. Okay, so for tamponade, I'd like to show you guys another slide which I have made. Oh, 1 second. Okay, so let's just go on to the next slide. Yeah. So what happens in tamponade? Basically, in cardiac tamponade, what you get is you get pericardial fluid. which is filling up the heart. So basically the heart, as you all probably know now, you guys have given step 1, right? So the heart is surrounded by, the epicardium and the pericardium, right? So in the pericardium, what you get is you start getting fluid. Okay. What happens is that since there's usually what happens due to rapid fluid accumulation in this, the high pressures outside in the pericardium cause compression of the right atrium. Why the right atrium? Because the right atrium is like, the chamber of the heart that has the lowest pressure, so it's easily compressed. When you get elevated right atrial pressure, right, this is transmitted backward into the vena cava. So this will cause an increase in the CVP. Okay. The decreased right-sided filling will cause less blood to be pumped through the pulmonary circulation, right? And hence, obviously, you'll get decreased, this is stroke volume and cardiac output, causing hypotension and shock. So in this case, the obstruction is by the pericardial fluid right outside the heart, which is basically compressing the heart. Okay. So although the volume of blood reaching the left atrium is reduced, right? Why is the left atrial pressure increased in this case? Because of, again, I told you, since there's fluid accumulating all around the heart, the left atrial pressure will also be increased. So this is not an elevation of left atrial pressure due to backup of fluid. This is due to compression of the left atrial pressure. So if we're able to if we put a Swan-Ganz catheter to measure the pressures within the heart, we would find an elevated PCWP in this case. But it won't be due to a backup of fluid. Remember that, right? So in this case, you're gonna get clear lungs. Why are you getting clear lungs? Again, because, if your right side of your heart isn't being able to fill, eventually due to it going to the pulmonary circulation, you won't get that much fluid in your pulmonary circulation, and there's no backup of fluid. So the elevation of pressure is due to the heart being compressed by the pericardial fluid. This is very important to distinguish from, for example, pulmonary embolism, because pulmonary embolism, in pulmonary embolism, you get a low wedge pressure, right? In this, you get a high wedge pressure, but both are causes of obstructive shock. So very important, lungs are clear because there's very low blood entering the right atrium in the first place to cause any pulmonary edema. So I want you guys to remember, don't worry, I have summary slides in the end, which we will go through. Okay, so let's see. So again, PCWP is elevated in tamponade. By falsely elevated, what I mean, it's not due to the backup of blood, right? It's not due to the backup of blood. It is because of the pericardial fluid putting pressure on the left atrium, and your wedge pressure will be raised because of this. Low in embolism, very important to distinguish. Other than that, obviously your CVP will be raised. Okay, because in obviously you have right-sided failure in embolism. Okay, you have right-sided failure in embolism, and you have pressure diastolic filling failure in tamponade. In your cardiac index would obviously be low, and if your cardiac index is low, you have a decreased SVO2, and because your cardiac output is low, your body will try to increase the SVR, okay, as we have already discussed previously. So now we've gone through 3 different types of shock. Okay, now I'm gonna try to go on to your final shock, which is distributive shock. Again, in distributive shock, another important thing to know is that for our purposes, anaphylaxis and septic shock, right? They are similar, not in presentation, but in parameters. Usually, I'll tell you a slight difference that I've never seen tested, but for the sake of completion, I've mentioned it in my slides. And neurogenic shock, which is a type of distributive shock, but it is easily, you can easily distinguish it. So what happens in distributive shock? So this is the only one in which you need to pay attention. It is systemic vasodilation, which leads to improper distribution of blood. So your vital organs are not getting, your heart, your brain, etc., are not getting the appropriate distribution of blood due to systemic vasodilation. So in this case, your SVR is low. Okay, so we're gonna start our discussion with septic shock. So what happens is septic shock is you have obviously bacteremia, which is bacteria in blood. They release their toxins, which cause systemic vasodilation, right? Your SVR, your resistance will fall. So SVR falling in this case, right, is part of the disease. Okay, so the in all the other types of shock, your SVR being raised was a mechanism to counteract the fall in blood pressure, right? In this case, the SVR is falling because it's part of the disease. Okay, so your afterload falls. You have a low blood pressure. When you have a low blood pressure, the body will respond by increasing activity of the increased activity, right? But obviously, again, as your sympathetic nervous system will be activated, your heart rate and contractility will increase. So what happens in this case is your cardiac index is increased in septic shock as well as anaphylactic shock. This is very important. These are the only two types of shock. So I won't say all types of distributive shock, but the septic shock is the most common cause. Anaphylaxis is also a very common cause. Your cardiac index is increased in this case, right? Why is that? Because obviously, so what's happening is I have a good heart, right? My heart rate is high. I have good contractility, right? And at the same time, the resistance against, the resistance, the afterload which my heart has to pump against has fallen. So it's very easy for the heart to pump out blood at very rapid rates. Okay, but the problem is the blood isn't getting to the right places and it's traveling really fast. So this is initially a hyperdynamic response. In the late phase, what happens is the cytokines lead to myocardial depression, which can lead to, this is wrong. I'm sorry about that. A decreased cardiac output. This happens eventually. Okay. But another important thing to tell you guys is that usually step 2 tests you only, I've only seen questions on the early phase because they want you to distinguish septic shock and anaphylaxis from other types of shock because they are the only two which have an increased cardiac index at first. Okay, for the sake of completion, obviously, eventually, if you're because of inflammation and cytokines, your heart does get depressed and eventually your cardiac output does fall in realistic scenarios. But for the sake of our step 2, it's important to know the early phase, which is the tested one. Another important distinction, warm skin. So because you have, in all other types of shock, you have vasoconstriction, and you're obviously when you're vasoconstricted, because of that, your temperature levels fall. In this case, due to peripheral vasodilation, you will find warm skin. Okay, so another important distinguishing thing. We'll move on to anaphylactic shock. Anaphylactic shock is basically what happens is any immunological anaphylaxis, IgE mediated or any non-IgE mediated, what happens is you get degranulation of mast cells, massive histamine release, again, systemic vasodilation with increased capillary leakage. This is very rapid in onset, as you guys have already studied anaphylactic shock, and it will present similarly to sepsis in terms of the parameters. Okay, but obviously anaphylaxis has different you can get a rash, you can have respiratory distress. It happens within minutes of the exposure. So you guys know how anaphylactic shock is different from sepsis. But again, heart rate, cardiac output will be increased. And at the same time, your SVR, etc., will be decreased. What happens in neurogenic shock? So basically in neurogenic shock, there is usually due to some trauma like spinal cord injury. Okay, spinal cord injury takes place. What happens is your sympathetic fibers, which are running from your, your hypothalamus and above, right? You get your sympathetic nerve fibers, they get injured. So when you have a loss of your sympathetic fibers, your parasympathetic basically is overactivated. In the normal human body, you have a good balance between your sympathetic and parasympathetic activity, right? So obviously, if I do not have my sympathetic system due to a spinal cord injury, my parasympathetic activity will increase. So what happens is you get bradycardia, which is again, vagus nerve stimulates bradycardia, which is the parasympathetic due to no sympathetic nervous system. Your SVR falls because your sympathetic nervous system is responsible for increased resistance. So you have vasodilation. You have a low cardiac output in this distributive type of shock because there is bradycardia. There is no sympathetic nervous system to cause increased contractility of the heart, right? So you will not have an increased cardiac index in this case because you have bradycardia and no sympathetic nervous system to increase the contractility of the heart. You have low venous tone, which can lead to low CVP and low wedge pressures. Okay. Again, this is due to the fall in the venous tone. Okay, 1 second. Okay. Okay. Okay, so these are some high yield step 2 points that I know people tend to forget. And I've just mentioned them here, and these can get you good points on the exam. So whenever you have spinal shock, right, and neurogenic shock with and you have absent sacral sparing. So that means your sacrum is also affected. You can find these signs can be, figured out on the exam. Like if you do an examination and the anal sphincter tone is like, is abnormal, right? So this is very important to know. That one of the first steps of management, obviously after resuscitation, is you have to place a Foley's catheter to relieve any acute urinary retention. Okay. And eventually you have to do intermittent catheterization. Sometimes what happens is that your sacral, in incomplete spinal cord injury, your sacral nervous system activates again and everything is all right. But if it's a complete injury, sometimes people completely lose their ability to contract their bladder. So this is very important that initial management does include placement of a Foley's catheter. Other things to note down in spinal cord injury is you need to have venous thromboembolism prophylaxis, ulcer prophylaxis, pain control, bowel care. These are all like, stuff they can ask you on step 2, which are important for management. Another important high yield point that I noted down is that your urine output is a very important surrogate measure to determine if the fluid resuscitation is adequate. This is because your kidneys are most sensitive. Your kidneys are most sensitive to react to changes in fluid status. Okay, so urine output is a surrogate marker to determine if your fluid resuscitation is good. They give you other options like lactate and base deficit in questions like this. For example, if they want to know if your fluid resuscitation is good or not, these are markers for prognosis, but the best for fluid resuscitation is your urine output. Okay. So basically, this is the summary of whatever I have taught today. In hypovolemic shock and cardiogenic shock, you don't have to worry about causes or anything like that, right? Your CVP will be low, your PCW will be low here, your SVR will be high, cardiac is low, SVO2 low. I've told you all the causes, right? If you have any questions, you can ask me at the end. Cardiogenic shock, again, CVP high, wedge pressure high, SVR high, low index, low SVO2. Obstructive shock, again, high CVP, right-sided failure or increased afterload. Wedge pressure, I remember in obstructive shock, I want you guys to note down wedge pressure. The differences are extremely important. In tamponade and pulmonary embolism, in tamponade, you have an elevated wedge pressure. You have a decrease. In tempora, you have an elevated wedge pressure due to the left atrium being compressed. In embolism, due to barely any fluid getting across the pulmonary embolus, which is stuck over there, you will have a low PCWP. SVR in general is high, cardiac index low, SVO2 low. Okay, what happens in distributive shock? We know it starts with a low cardiac, that SVR, the low SVR causes the sympathetic center, because your cardiac index will increase. Oh yes, another important thing that I wanted to tell you, because again the cardiac index is high in this, but the way I think of it is that, like, you have fast flowing blood, it has no resistance at all, so your tissues will not be able to extract the oxygen to the maximum content. So the oxygen that is found in the veins, right, that will be high. Okay, because the in sepsis, anaphylactic shock, the blood is traveling so high and so fast that your tissues are not able to extract the oxygen. But if you guys can record it that way, then just remember, jahan bhi, wherever like you have cardiac index is high, your SpO2 will be high as well. Okay. Again, I've just summarized this. You guys know all this. This is very important to look at PCWP. I think this is due to left atrial pressure. This is due to again, the fluid isn't being able to cross the embolus, so there's less pressure. Okay, so you will have clear lungs. Okay, okay, so this is one extra point. I've never seen this tested, but I'll just tell you. So, the wedge pressure, just try to learn that it's very low in anaphylaxis and neurogenic shock. It is usually low in sepsis, but if it's normal, it's like this can be found as well. There's just something to note, and don't worry, we will give you the slides after. So if you want to know this, it's important. Your wedge pressure can be normal or low in sepsis, but usually in anaphylaxis and neurogenic shock, it can be extremely low. Okay. All right. So if you guys can do, I have 2 questions. If you guys can solve these, it will be great. And then hopefully, we can discuss more on the group. So just try to answer these questions. So it's an 82-year-old woman is brought to the emergency department from a nursing facility due to confusion and altered behavior. She had 3 episodes of diarrhea the last 4 days. Her temperature is 37, 78/49, 110, disoriented. Pulses are weak. When you place the Foley catheter, you get foul odor. Which of the following is the hemodynamic parameters? So if you guys can tell me that. Ready? 1 second. Okay, so we have a message here. Okay, anyone else? Can anyone else answer this question? If you guys, okay, C. Okay. Okay, so I'm not sure what your name was. Phosphatidylcholine. Can you tell me why you think it's C? Can you tell me what, like, what they're facing, like which shock, what kind of shock is the patient, 80-year-old, 82-year-old woman facing? Okay, mine says B. Okay. Okay, so yeah, so the answer of this question is B. If you guys weren't able to solve it, so the patient, a very common cause of sepsis in especially older patients is a cause of sepsis is a UTI. UTI can lead to sepsis. So this patient is undergoing sepsis. So you can tell it's shock because the blood pressure low, you have high heart rate. So they're asking you sepsis, which is septic shock, which is a type of distributive shock. So we know that in this case, your SVR should be low, right? Your SVR should be low. Your cardiac output will be high because, again, I've already explained this, and your wedge pressure can be decreased or normal, right? And your CVP will be decreased, okay? Because, you don't have any, you're highly vasodilated. If you don't have any tone in your vessels, obviously your CVP will be low. Another question, last question of the presentation. So here, what you have is a 76-year-old man brought to the ED by ambulance after being found unconscious in his bathroom. Upon asking the attendant, he's found to be a known case of diabetes, hypertension, and he has 2 DVTs. He's a truck driver by profession. Temperature is this, 36, pulse is 127, respiration at 25, and your blood pressure is 70/40. He does not open his eyes, but but does withdraw from pain. Okay. Your pressures shown increase CVP, increase wedge, and increase SVR. Which of the following is the most likely explanation? Okay. You think you guys can try this? Okay, someone has already answered E. E. Okay, good. Okay, yeah, that's great. So yeah, the answer of this question is E as well. Why and sorry, is E in this case because as you can see, I gave the history of DVT and truck driver just to maybe confuse you guys a bit. But in this case, as you can see, you have an increased CVP, increased wedge pressure, and increased SVR, right? So if it's in the only, honestly, the two confused you could get between is a massive pulmonary embolism due to the history and the profession, and acute MI. But the main difference you can see is increased wedge pressure. And as I told you before, in pulmonary embolism, you have a decreased wedge pressure. So it's very important. These are the type of questions which come on step 2. And it's very important to distinguish, the different parameters. You'll be able to solve most of the questions. These are the way they're tested. Other than this, we'll continue on the group, hopefully. Okay. Yeah, Shahjeb is right. It's important to look at the presentation first and look at the etiology later. Okay, so yeah, I think that